everybody. I'm Renwick from NHS England. We were a patient online team, but that is no more. We're not a programme anymore in relation to patient online. We've been split, so we've had a big reorganisation. So as an implementation lead, I'm now part of the Empower the Person team. And the patient online is still very much part of that, but there's also lots of other things that are incorporated into that as well, like online consultations, NHS 111, and online consultations is another as well. And it's about, and GP Wi-Fi is another one as well. So it's just about how we now sort of align with all those other offers in relation to digital offers and things like that. We do have half of the team who went into the other pillar, if you like, and that's supporting and digitising the clinician. And that will be our clinicians who we still work with and we still have a lot of sort of involvement with and who will still help us. But it'll also be our engagement and support team as well. One of whom's here today and who's manning the stand with me out there, so please come and speak to us in the break if you need to. So that's just a little bit overview really of what's happened with the programme, because it isn't a patient online programme anymore, it's very bigger. So really, I'm aware that a lot of the practices in the room now are probably are very proactive in relation to patient online, but I think there's still a lot of myths out there about people who are older don't use the internet, and there's lots of people who still don't. But actually 90% of adults now have access to the internet, and 80% of those adults access the internet on a daily basis. So that actually could be used like a smartphone or anything like that. Interestingly, 1 in 4 users are over the age of 55, and so absolutely, the older generation are using online services a lot more now. So what I want to just go through today is a few myths, because there's a lot of confusion over ID verification in relation to patient online. And we still hear of practices who insist on having photographic evidence before they register patients for online services, and that is a big barrier. That's providing that's actually our patients are finding they're having to go away and come back with ID, and a lot of the times they don't. There's 3 approved methods. Yes, sorry, it's because I need to click. I haven't got a clicker. So sorry. Yeah, sorry for that. So one of the ways of ID verification is vouching, and I think a lot of you might use that, and that's just by your members of staff in your practices being able to vouch to say that person standing in front of you is the patient. And for those staff who've been in your practices for years, that's often very, very easy to do. And there's also vouching by confirmation of what's in the record. So you could ask the patient standing in front of you a few questions, not just demographics. Ask questions around maybe when did what was your last operation for, what were you last prescribed, what was your last acute medication. Ask them those types of questions to be able to confirm their ID that way. And a lot of these patients as well who might ask for it are coming to see nurses maybe regularly. And the nurse is clearly carrying out a treatment on that patient, and not going to do that unless they're quite confident that the person presenting as a patient. Again, use that sort of resource as well to be able to vouch for those IDs. We do say though, for access to records, we do actually would always advocate maybe having a look at some documentation in relation to the access to records side. That's more for the transactional services side. So just very quickly, as I say, I just wanted to go through that. Children and young person, again, it is acceptable to allow children to have access. Obviously, there's issues around competency and things like that. Competency have to be assessed from the age of 11. If they're not competent to manage their own record, the proxy may continue to have access at that point. If they are competent to manage their own record, I must admit not many children age 11 will be competent, but that is what the guidelines are. Then obviously the child can have access to be able to order their repeat meds and things like that. Again, there's lots of information around children and young persons on the RCGP website, and we have a video that's on there, like e-learning, and that's only about 10 minutes long, so it doesn't take a long time to sort of go through it, as we have for the ID vouching as well. So really what you need to know about online access for children and young persons. think about your clinical system and learn what the configuration and cut-off times are. Depends upon your clinical system, what the cut-off times are. EMIS practices, I think, are you all EMIS practices? Yeah, so EMIS, at the moment you'll be going through some system upgrades, so that will change, so it will change very much what's happening around your age cut-off and things like that. But if you want to talk to us separately about that, I can do in the break time. So milestones to be aware of, obviously under 11s, getting up to that 11, and then 11 to 16, that's when you've got to obviously, you know, sort of monitor the competency of that child during that period, because just because they're not competent at 11 doesn't mean to say they won't still be competent at 15, 16, etc. And then 16 plus. There's obviously potential benefits there, particularly around new clients and new patients. And new parents, so think about the young children sort of vaccination programmes when parents are bringing their kids in, you know, for the baby IMS and things like that. Try to capture and use that as an opportunity to capture new sort of online users at that point. And obviously children and young persons with long-term conditions as well. So these are our promotional materials. We've got a few out there just to sort of show you. They're all available free of charge. Do you all have these in your practice, the blue and yellow ones? Right, these were introduced, I think, well over a year ago now. And they can be ordered free of charge from the DOH order line. You are limited to what you can order, but you can order it on a monthly basis. And just a little tip, I know I'm really not supposed to say this, the system is not intelligent enough to work out that your practice hasn't ordered the full quota, so you can have 3 people in the practice ordering because it's based on username rather than practice. Okay, so just a little tip for the bigger practices, makes it easier than phoning up and asking for more supplies. And there are our resources. So you've got the NHS England patient online page, and the RCGP learning page, which I referred to earlier on today, is on the right hand side, with all the e-learning modules for your staff and for yourselves as well to do. So obviously NHS Wi-Fi, I did touch on that earlier on. We've got practices now who is benefiting from the NHS Wi-Fi, who are advising their patients to download the Patient Access app, for example, whilst they're in reception, and helping the patients register for online services while they're actually in practice now. So that's just something that is just a little bit more there for the patients and be able to help them to register and increase your registrations. Now, we do have a commitment that the Secretary of State's made, and he wants to increase usage of appointments and availability of appointments. Obviously, with the onset of online consultations, we know that a lot of practices probably don't want to offer GP appointments online because you're circumnavigating the online consultation, and that's absolutely not. We fully acknowledge that. So it's about looking at what you can increase and looking at what you can expand on. And one of those areas is nursing appointments. Now, as an AIMS practice, you can offer quite a lot of nursing appointments online. That's very obvious to the patient, the type of appointment it is. Does anybody offer online nursing appointments at all? Yeah, and it works all right? You don't have any problems?
Doing them 2 sets at the moment.
Right.
Smears is going to do well.
Which ones have you got on?
That's
on one of my slides actually, so we'll have a bit chat about that as well. That's great. So this is the GP Online Services contract for this year. In the GMS contract, practices under 10% are to work with NHS England to achieve greater use of online services. NHS England in this respect is the commissioner, because it's always NHS England when mentioned in the contract is the commissioner, so it could actually be the CCGs depending upon delegated budget and things like that. And there's a joint commitment to aim for 30% now of your registered patients for online services. Practices who have patients registered for and using online services are now seeing real benefits from this, and it's about the offer. I could go into my practice who does no triage, no online consultation, and I could go on and there will be no GP appointments for me to book on my app. I'll ring the practice and they'll say, yes, Kate, come in on Friday morning and we'll book, and you know, you can see such and such GP. Why couldn't I book her on the app? Why couldn't I book her online? So it's about thinking about, it's equal access. So you're not removing those online access appointments for those people who were ringing, you're making a depot, so everybody, regardless of the access channel, could book in at 9 o'clock on Friday morning, and our available appointment, basically. Right, I'll just click down there. So there's all sorts of types of appointments. I'm not going to go through them. Some are untimed appointments, some of them face-to-face, some of them telephone triage appointments. I'm not going to go through them all now, but we will circulate this information. It's not something that we've developed ourselves, sitting in an office in the middle of in London somewhere. It is something that when we visited the practices, this is the information that we've gleaned from all the practices, right throughout the region. So these are the common queries about patients booking into appointment slots. Is the patient booking into incorrect slots? Mixed clinics, so you think, well, I can't put a SME appointment on, for example, on a Friday morning because the nurse just doesn't deal with that. Different time slots depend upon need. GP appointments are triaged, the use of care navigation. Obviously, you don't want to put the actual GP appointments on for the patients to certainly navigate, which I mentioned earlier on. And obviously being aware of your system variations around that as well. But just a few helpful hints and tips. Appropriate use of the free text screen. I know it's very limited with EMIS, but you can actually, if you consider using just what characters you've got quite intelligently, try to direct your patients. Allow patients to book more than 1 or 2 future appointments in your config. I've got an example of that in a slide that I'll just discuss later. And configure individual patient online permissions to prevent misuse of appointment bookings. And that is, if you do, a lot of practices will say to me, I don't want to increase my config for my patients to book 1 or 2 because they'll abuse it and they'll start booking lots of appointments that they don't need. When I show you this scenario later on, you'll appreciate why that might be needed. And if you do have patients who's going to abuse it, take the appointment setting away from them. Obviously warn them first, but actually remove that from them. If they don't let 1 or 2 patients spoil it for the rest of the patient group, absolutely do that. And DNAs, promote online services for DNA. It doesn't matter if your appointment's being made online, if it's being sort of released for online, it doesn't make any difference. The patient will still see that appointment to cancel. So I have a nursing appointment a week on Monday. My practice doesn't put nursing appointments online at all. So they've had to book it for me. I can actually go in and cancel that because I can see that appointment and I can do that. So it does reduce your DNAs. So I'll just show you a few scenarios here. And it's the nursing appointments. I'll just put that all up and then... Right, so it's a long-term condition patient. This is based on your config, on your number of appointments that you've enabled. So the appointment is not able to book online, therefore reception staff have made the booking. It's a 20-minute appointment made up of 2 consecutive 10 minutes, so that's 2 appointments basically that patient's got. The patient wishes to book to see a GP for that week, but is unable to do so because the config's only set to 2 appointments. Because of that, even though it wasn't enabled for online and even though it wasn't made online, that patient cannot see or cannot make a GP appointment that week or another nursing appointment if he chooses to do so. So it is actually preventing patients from using it. When you think about EMAS config settings. So it's about thinking what would actually work better for your practice. So amend the configuration within the clinical system and that will help. The other one is the nursing appointments, and this is DNA, and actually this is a real life sort of scenario. This has actually happened. So we've got a 21-year-old with an asthma review appointment on Friday. She realises at 9 o'clock on Thursday night that she cannot attend because of additional work commitments. So without online access, she would have rang the practice at 8 o'clock on the Friday morning. She would have been in a long queue and she would rather do her hair and do her makeup, and she puts the phone down and thinks, I'm not going to hang on, so it's a DNA. With online access, she literally goes in on patient access and she cancels it. Unfortunately, because the practice doesn't offer online, she can't rebook it, but at least she's been able to sort of cancel that appointment, and it makes it available for other people. So this one for me is probably one of the bigger ones, and this is like your cough point and your cost, and obviously saving lives as well. So we've got a 52-year-old female, and this is a real life scenario as well. Works long hours, requires a SME test, and they don't have the opportunity to book during the day because it's just completely overlooked. They remember it's 10 o'clock at night, but it's too late because that particular practice doesn't have those appointments online. So what we're saying is try to enable the appointments. It would be interesting to know what your QOF return was, because I was talking to a practice in Liverpool who've done this for the last year, and their QOF return was 82% for this, which is 2% above what you need for 100% QOF points and miles above the national average. So it's just, you know, thoughts around that. We already know that offering those appointments online works really well. And obviously the risk is that the patient's not identified for early diagnosis as well. So it could result, you know, in a life-threatening sort of situation for that particular patient. There was nearly 68 million of unclaimed QOF money in 16-17. I don't know what the results are for 17-18. It hasn't been published yet. Not all of it was related to appointments, but a lot of it is sort of related to where patients haven't necessarily turned up for appointments or where our information hasn't been gleaned to be able to input into your system for that to be collated. So just food for thought. So do you think sort of putting that type of appointment online would help a lot of practices? Do you think that is something that you think actually I could actually do that? Obviously you need to promote it, you've got to offer it so your patients are aware it's there. But clearly it's working, you know, for you. It's working for a practice that I've just spoken to in the Liverpool area. As I say, she sent me the QOF return, that the snapshot of that QOF, and it was 82% that they actually got, which is, I think, what's the national average? About 67 or 60? Something like that. So it's extremely low. So that's, you know, massive compared to that. And getting started. I'm not going to go over and over it because I'm aware that we're a bit pushed for time. I will send this out, but it's all around system config, just what I've been talking about. Thinking about the numbers of appointments you've got. Think about what you call, if you actually offer a smear, because AMIS practices can actually show the patient what that button is, if you like, so that the patient will see smear, they'll click into smear, it'll take it to the right clinician to the right time scale. Think about what you call that. Phlebotomy, for instance, a patient will not know what phlebotomy means properly, so think blood test. Ask your PPG group what's the best sort of title, if you like, to call it so the patients will use it correctly. And I do know I was a senior clinician who was on the patient online programme, did have one guy who booked in for a smear last year. He only booked in once, he didn't book in anymore. And that's actually true. So this is just really around switching the process. At the minute when a patient rings, long-term condition patient, there's a practice what you would do, what your reception staff would do to make sure that that patient is right for that type of appointment, and they would sort of check the record first. All you're doing by putting some of the nursing appointments online is maybe just checking at the end. And because patients will get used to doing that, you'll find less and less and less checking will have to be done, and the patients are booking in correctly and into the right slots. So, getting started again. If you're a little bit worried about it, just think about maybe offering an hour a day worth of sessions, and then build it up and see how that goes. Start with the appointment type that will work better for you in the practice. I know I've used a couple of examples, but you might think actually, I was in Lancaster, for example, and they said they would prefer to start with health checks, and they think the NHS health checks would be better to start online. It's got to work for you as a practice. Think about what will work better for you first. Obviously, monitor your free appointments, because your staff can still override those appointments, even if they've been sort of specified for a specific type. I think I'll just leave it there, because I think I'm aware I'm out of time. Yeah. That's it, to be honest. That was it. So great.